Good day, I'm Dana Champagne Amba. I will be reporting coarctation of the aorta. Definition of the coarctation of the aorta. Localized narrowing near the insertion of the ductus arteriosus, which results in increased pressure proximal to the defect, head and upper extremities, and decreased pressure distal to the obstruction, body and lower extremities. Etiology, genetics, congenital defect that occurs within the family. Congenital heart defects like coarctation of the aorta usually occur by chance with no clear reason for their development. Doctors are not sure why some people develop coarctation of the aortas, but boys are almost twice as likely to have it than girls. Presence together with other cardiac complications, common in females who have Turner syndrome. Types: infantile form or predactyl type, characterized by diffuse hypoplasia or narrowing of the aorta from just distal to the brachiocephalic artery to the level of ductus arteriosus, typically with a more discrete area of constriction just proximal to the ductus but distal to the origin of the left subclavian artery. Therefore, the blood supply to the descending aorta is via the patent ductus arteriosus. Constriction or narrowing exists between the subclavian artery and the ductus arteriosus. Next is ductal coarctation. The ductus arteriosus narrows at its point of insertion. This type is typically seen when the ductus arteriosus closes. Next, adult form or juxtaductal, postductal, or middle aortic, characterized by a short segment of drop stenosis of the postductal aorta. It is due to thickening of the aortic media and typically occurs just distal to the ligamentum arteriosum, a remnant of the ductus arteriosus. The constriction or narrowing is distal to the ductus arteriosus. Disease process. Coarctation of the aorta occurs as a congenital birth defect in infants and children. It manifests as localized narrowing near the insertion of the ductus arteriosus, which results in increased pressure proximal to the defect and decreased pressure distal to the obstruction. Due to this, symptoms like shortness of breath, chest pain, systolic murmur, high blood pressure, bounding pulses in the arms, weak or absent femoral pulses, cool lower extremities, lower blood pressure are present, among others. Patients are at risk for hypertension, ruptured aorta, aortic aneurysm, bacterial endocarditis, and stroke. Assessment. Risk assessment. Possible assessment that can be done to manage possible onset of disease. We have physical examination to check for heart murmurs. It helps determine the cardiac behavior of the child, such as heart sounds, to notice deviations that can be indicators of congenital heart defects. Fetal echocardiogram is a type of test that can help diagnose heart defects. A fetal echo uses sound waves to create a moving picture of the heart. This helps doctors see how the baby's heart looks and works while still in the mother's womb. And we also have here MRI or magnetic resonance imaging and computed tomography scan to produce images of the heart. Signs and symptoms. Babies with severe coarctation of the aorta may begin having symptoms shortly after birth. These include shortness of breath, chest pain, irritability, systolic murmur, hypertension, bounding pulses in the arms, weak or absent femoral pulses, signs of heart failure or HF in infants, breathing trouble, poor feeding, poor growth, excessive sweating, dizziness, headache, pale or gray appearance, nosebleed. And fainting. Diagnostic test, chest x-ray, can identify cardiac hypertrophy, chamber and great vessel enlargement, and dilation of the pulmonary vasculature. This gives an overall picture of your child's heart and lungs. Electrocardiogram or ECG. During this procedure, patches with wires electrodes are placed on your chest, wrist, and ankles. The electrodes measure electrical activity in your heart, which is recorded on paper. This test helps determine if the muscular wall of your right ventricle is thickened, right ventricular hypertrophy. This test measures the electrical activity of the heart. Echocardiogram. Echo. Sound waves bounce off your heart and produce moving images that can be viewed on a video screen. This test is useful for checking the structure of the pulmonary valve, the location and severity of the narrowing, stenosis, and right ventricle size and function. This test uses sound waves to give a moving picture of the heart and valves. Next, cardiac catheterization is a procedure in which a thin, flexible tube catheter is guided through a blood vessel to the heart to diagnose or treat certain heart conditions. During this procedure, your doctor inserts a thin, flexible tube catheter into an artery or vein in your groin and threads it up to your heart or blood vessels. Dye injected through the catheter makes your blood vessels visible on X-rays. Doctors also use cardiac catheterization to measure the blood pressure in the heart chambers and blood vessels. Next, pulse oximetry. This non-invasive test measures oxygen levels in the blood through a clip placed on a finger. Next, we have other imaging tests. We have MRI or magnetic resonance imaging and computed tomography or CT scans are sometimes used to confirm the diagnosis of aortic stenosis. Nursing diagnosis, we have here ineffective breathing pattern, shortness of breath related to low blood oxygen levels. The body will try to compensate for low blood oxygen levels by making the body breathe in more air. Hence, there is an increase of the respiratory rate as the body tries to supply more oxygen for the brain and other vital organs. Next, decreased cardiac output decreases in peripheral pulses related to altered stroke volume. With coarctation of the aorta, there is hyperperfusion towards the extremities, hence low blood pressure and absence of pulse in the periphery of the body is manifested. Next, risk for injury related to syncope due to limited blood flow. Fainting is a common symptom of this condition because the body gets less oxygen and blood flow is obstructed due to narrow aortic arch. Hence, the client is at risk for falling and thereby causing injury to themselves. Next, in nursing interventions, monitor vital signs closely. Compare blood pressure in the upper and lower extremities to detect abnormalities such as coarctation of the aorta in which the lower extremity pressure is less than the upper extremity pressure. Monitoring and reporting blood pressure and pulse differences in upper and lower extremities. Instruct the client to avoid walking around alone and instruct the significant others to keep the client company at all times. Preparing and caring of the child and family when invasive procedures are to be performed. Educate the family about the disorder and assist in making necessary adjustments. Educate the family on home management of the disease. Educating about treatments and possible complications. Aorta can narrow again at some point and will require a procedure to reopen. Hypertension. Some child can continue to experience hypertension long-term and will need medications to control. Long-term follow-up care with a cardiologist. Monitor the client closely after a surgical procedure and provide emotional support. And next, medical interventions. Cardiac catheterization is a procedure in which a thin, flexible tube catheter is guided through a blood vessel to the heart to diagnose or treat certain heart conditions. Next, balloon angioplasty. A tiny balloon is inserted into a blood vessel in the leg and a very thin wire is threaded up to the aorta across the narrow area. And next, cardiac magnetic resonance imaging is a preferred advanced imaging modality for non-invasive diagnosis and a follow-up of coarctation of aorta and allows evaluation of vascular anatomy outside of heart. Next, we have here pharmacological interventions. We have prostaglandins, keeps the ductus arteriosus open, will be given so that enough blood flows in the lungs. Next, intravenous sodium nitroprusside, esmolol or milrinone for postoperative hypertension. Next, diuretics help treat symptoms of heart failure. And next, analgesics for headache. And next, for surgical intervention, we have resection with end-to-end anastomosis. This method involves removing the narrowed segment of the aorta, resection, followed by connecting the two healthy sections of the aorta together, or anastomosis. Next, subclavian flap aortoplasty, a part of the blood vessel that delivers blood to your left arm, or left subclavian artery, might be used to expand the narrowed area of the aorta. Next, bypass graft repair. This technique involves bypassing the narrowed area by inserting a tube called a graft between the portions of the aorta. And next, patch aortoplasty. Your doctor might treat your coarctation by cutting across the narrowed area of the aorta and then attaching a patch of synthetic material to widen the blood vessel. Pathophysiology of the coarctation of the aorta. We have here predisposing factors: defect in a gene, chromosomal abnormality, severity hardening of the arteries, atherosclerosis, inflamed arteries, Takayasu arteries. For precipitating risk factors, we have maternal drug abuse, alcohol abuse, maternal infection, radiation exposure. Etiology: it may cause by improper aortic development during the first 8 weeks of fetal growth. The aortic narrowing found in coarctation of aorta means that the left ventricle must pump at a far higher pressure for force the blood through the narrow segment that results in less oxygen-rich blood reaching the lower body. It may lead to cardiac failure wherein major organs proximal to the coarctation may receive reduced blood supply. Next, signs and symptoms. We have labored or rapid breathing, weak femoral artery pulse taken in the groin area, heavy sweating, poor growth, pale or gray appearance, heart murmur, extra heart sound heard when the doctor listens with a stethoscope. And for the management, we have here nursing interventions, monitor vital signs closely, compare BP in the upper and lower extremities, instruct the client to avoid walking around alone, and instruct the significant others to keep the client company at all times. Prepare and care of the child and family when invasive procedures are to be performed. Educate the family about the disorder and assist in making necessary adjustments. Educate the family on home management of the disease. Monitor the client closely after a surgical procedure. Provide emotional support. For medical interventions, we have cardiac catheterization, balloon angioplasty, and cardiac magnetic resonance imaging. For pharmacological interventions, we have prostaglandins, intravenous sodium nitroprusside, esmolol or milrinone, diuretics, and analgesics. For surgical interventions, we have resection with end-to-end anastomosis, subclavian flap aortoplasty, bypass graft repair, and patch aortoplasty. Here are the relevant pictures related to coarctation of the aorta. Nursing care plan of coarctation of the aorta. We have here needs, problems, cues, nursing diagnosis, scientific basis, objectives of care, nursing actions, and rationale. First, needs, problems, and cues. We have physiologic deficit, ineffective breathing pattern. For objective cues, we have your vital signs taken as follows. For temperature, we have 36.9 degrees Celsius. For pulse rate, 95 beats per minute. For respiratory rate, 28 breaths per minute. Next, shortness of breath, chest pain, high blood pressure in the upper extremities, low blood pressure in the lower extremities, headache, epistaxis, or nosebleed. For subjective cue, we have nakuyawan ako sa akong anak kay paspas kaayo siyag og hinga murag naglisod siyag ginhawa as verbalized by the mother. For the nursing diagnosis, ineffective breathing pattern, shortness of breath related to low blood oxygen levels. For scientific basis, a normal body response to increase blood oxygen levels is to increase the respirations of the host. Hence, rapid breathing is the body's survival mechanism to prevent hypoxemia and hypoxia. Due to this survival mechanism, shortness of breath and headaches manifest, Coarctation of the aorta causes less blood flow towards the body because its narrowed path, so less blood out means less oxygen for the body. If this is prolonged, serious complications like stroke and heart failure can affect the brain and vital organs. For the objectives of care, we have general objectives. After 1 week holistic nursing client interaction, the client will be able to achieve normal respiratory function. For specific objectives, after 8 hours of holistic nurse-client interaction, the client will be able to first ease rapid breathing, second reduce and or resolve other signs and symptoms. For the nursing actions and its rationale, for nursing actions, measures to improve ventilation. Independent, we have evaluate skin color, temperature, capillary refill, observe central versus peripheral cyanosis, its rationale to note any symptoms that can be used for the diagnosis. Second, place the patient with proper body alignment for maximum breathing pattern. Proper positioning will yield more air for the client to take in. Number 3, provide emotional support. Easing the client's anxiety may resolve the shortness of breath. For dependent, we have administer vasodilators as ordered. Its rationale, the doctor may want to dilate the client's blood vessels to facilitate flow. Number 5, assist physicians with diagnostic exams to ensure safety and efficiency of the procedure. For interdependent, number 6, collaborate with pediatric cardiologists. The cardiologist will decide the surgery needed by the patient. Number 7, collaborate with client surgeon to prepare the client and family for the upcoming procedure the client will be having. Again, I'm Dana Champagne Amba. I will be reporting tetralogy of Fallot. The definition of tetralogy Fallot is a birth defect that affects normal blood flow through the heart. It happens when a baby's heart structure does not fully form as the fetus grows and develops in the mother's womb during pregnancy. This birth defect is considered a critical congenital heart defect and may put the baby at risk. The classic form includes 4 defects. First, the ventricular septal defect or VSD. Second, pulmonic stenosis. Third, overriding of the aorta. And fourth, right ventricular hypertrophy. Etiology, causes of heart defects such as tetralogy of Fallot among most babies are unknown. Some babies have heart defects because of changes in their genes or chromosomes. Heart defects such as tetralogy of Fallot also are thought to be caused by a combination of genes and other risk factors such as a higher risk of getting an infection of the layers of the heart such as endocarditis, a higher risk of having irregular heart rhythms or arrhythmia, dizziness, fainting, or seizures due to the presence of low oxygen levels in their blood, and delayed growth and development. Next, types. Types in terms of classifications that make up the tetralogy of Fallot include pulmonary valve stenosis. Pulmonary valve stenosis is a narrowing of the pulmonary valve in which the valve separates the lower right chamber of the heart, right ventricle, from the main blood vessel leading to the lungs, pulmonary artery. Next, ventricular septal defect. A ventricular septal defect is a hole in the septum that separates the 2 lower chambers of the heart, the left and right ventricles. This hole allows the oxygenated blood in the right ventricle to flow into the left ventricle and mix with the oxygenated blood. Blood from the left ventricle also flows back to the right ventricle in an inefficient manner. This ability for blood to flow through the ventricular septal defect reduces the supply of oxygenated blood to the body and eventually can weaken the heart. Next is the overriding aorta. Normally, the aorta branches off the left ventricle. In tetralogy of Fallot, the aorta is shifted slightly to the right and lies directly above the ventricular septal defect. In this position, the aorta receives blood from both the right and left ventricles, mixing the oxygen-poor blood from the right ventricle with the oxygen-rich blood from the left ventricle. And next, right ventricular hypertrophy. When the heart's pumping action is overworked, it causes the muscular wall of the right ventricle to thicken. Over time, this might cause the heart to stiffen, become weak, and eventually fail. And we also have ear types in terms of severity. We have mild or pink TOF. This is usually asymptomatic, and infants with this have mild pulmonary valve stenosis or right ventricular hypertrophy. Usually progresses as the child and the heart grows and will develop cyanosis within the first 3 years of life. And next, we have moderate severe cyanotic TOF. Infants with moderate severe pulmonary valve stenosis may have cyanosis and respiratory distress within the first few weeks of life. Infants under this are at risk of developing recurrent chest infections or fail to thrive. Lastly, we have extreme. This can be classified further into TOF or tetralogy of Fallot with pulmonary atresia, which is present in 10% of TOF patients, or absent pulmonary valves, present in 6% of patients. It is considered through duct-dependent lesions, as the only way the oxygenated blood can flow into the lungs is through a patent ductus arteriosus. Infants under this complication with this severity may be detected on antenatal scans, but if unable to do so, they will be present within the first few hours of life with evident cyanosis and respiratory distress. Disease process. Tetralogy of Fallot is a combination of 4 abnormalities or defects that alters fetal development and possibly endangers it. With an overriding aorta, the aorta is considered to be too large as well as it's in the wrong position, causing it to receive a mix of oxygen-rich and oxygen-poor blood. Pulmonary valve stenosis has the narrowing of the pulmonary valve, reducing blood flow. Ventricular septal defect constitutes a hole preventing ventricular wall closure. Right ventricular hypertrophy increases ventricular contraction due to the thickness of the right lower chamber, causing it to overwork. All these defects contribute to the decreased oxygen present in systemic circulation. Assessment, risk assessment, ultrasound may identify the complication being present and may request an additional fetal echocardiogram to confirm diagnosis. Physical examination, assessment of skin if it appears to be bluish or presence of a heart murmur. Next, newborn screening using pulse oximetry. It estimates the amount of oxygen in a baby's blood. The test is done using a machine called a pulse oximeter with sensors placed on the baby's skin. Low levels of oxygen in the blood can be a sign of a critical CHD. Congenital heart defects. Next, we have your TET spell. Monitor and manage hypercyanotic spell, TET spell, due to cerebral anoxia. It consists of irritability, dyspnea, cyanosis, flaccidity, with or without unconsciousness. It is found in the morning after awakening, during or after feeding, and painful procedures. Signs and symptoms. We have here a bluish coloration of the skin caused by blood low in oxygen cyanosis. Children with tetralogy of Fallot exhibit bluish skin during episodes of crying or feeding. Next, shortness of breath and rapid breathing, especially during feeding or exercise. Loss of consciousness, fainting, clubbing of fingers and toes, an abnormal rounded shape of the nail bed. Poor weight gain, tiring easily during play or exercise, irritability, prolonged crying, a heart murmurs. Diagnostic test. We have your physical examination. Patients with tetralogy of Fallot appear small and is usually remarkable for cyanosis, systolic trill, systolic ejection murmur, and clubbing. Next, Doppler echocardiography confirms the presence of pulmonary atresia as opposed to narrowing of the right ventricular outflow tract, which is more typically seen with tetralogy. Next, electrocardiogram. Electrocardiogram records the electrical activity in the heart each time it. During this procedure, electrodes are placed on the infant's chest, wrist, and ankles. This test helps determine if the right ventricle is enlarged, right ventricular hypertrophy, or if the right atrium is enlarged and if the heart rhythm is regular. Next, chest X-ray. A chest X-ray can show the structure of the heart and lungs. A common sign of tetralogy of Fallot on an X-ray is a boot-shaped heart because the right ventricle is enlarged. Next, pulse oximeter. This test uses a small sensor that can be placed on a finger or toe to measure the amount of oxygen in the blood. Next, cardiac catheterization. This test to determine and assess the structure of the heart and its surgical procedure to be done. A catheter is inserted into an artery or vein in the arm, groin, or neck and threads it up to the heart. A dye is inserted through the catheter to make the heart structure visible in X-ray pictures. Cardiac catheterization also measures pressure and oxygen levels in the chambers of the heart and in the blood vessels. Nursing diagnosis, we have here decreased cardiac output as evidenced by shortness of breath related to the obstruction of the right ventricle. In babies with TOF, the obstruction in the right ventricular outflow tract limits how much blood flows to the lungs. Over time, the obstruction gets worse. Once the obstruction becomes severe, the pressure will become higher on the right side than the left. At that point, the blood will flow through the VSD from the right ventricle to the left ventricle. Since the blood in the right ventricle is lower in oxygen, this will lead to lower oxygen levels in the blood. Next, impaired gas exchange related to altered oxygen supply as evidenced by dyspnea, cyanosis, and clubbing of fingers. With the ventricular septal defect, this separates the two lower chambers of the heart, making way for the mixing of oxygen-poor blood and oxygen-rich blood, reducing the supply of oxygenated blood, indicated by the occurrence of cyanosis, dyspnea, and clubbing. Next, activity intolerance related to imbalance in the fulfillment of oxygen to the body's needs. Activity intolerance occurs due to the impaired function of the heart and lungs with the circulation of the oxygenated blood in the body providing less energy. Nursing interventions monitor the oxygenation and cardiac status of the baby. Next, knee-chest position in effort to increase systemic vascular resistance. Knee to chest position. When an exacerbation of symptoms occur, the child is placed in a knee to chest position. Flexion of the legs provides relief of dyspnea, as this angle improves oxygenation by reducing the volume of blood that is shunted through the overriding aorta and the ventricular septal defect. Soothe patients during TET spells to calm them down. Check for peripheral pulses including capillary refill. Weak pulses are usually present in reduced stroke volume and with cardiac output, thus capillary refill is low in babies with TOF or tetralogy of Fallot. Assess heart sounds for gallops. Third sound and fourth sound. Third sound indicates reduced left ventricular ejection and is a class sign of left ventricular failure. Fourth sound occurs with reduced compliance of the left ventricle, which impairs diastolic feeling, and provide support for the family while waiting for the newborn to undergo surgical intervention. Medical interventions. We have here electrocardiogram for rate, rhythm, and ectopy. Cardiac dysrhythmias may occur from low perfusion, acidosis, or hypoxia. Tachycardia, bradycardia, and ectopic beats can further compromise cardiac output of the infant's heart. Next, volume expansion with IV fluid. It is to supply enough fluid to a baby. The baby will receive fluids through a tube inserted into a vein. Next, high flow oxygen inhalation. If the patient is experiencing pulmonary edema and respiratory failure, the patient needs this kind of support, which is the mechanical ventilator. Next, pharmacological interventions. We have here propranolol. It reduces pulmonary and valve spasm. Next, phenylephrine causes vasoconstrictions and may facilitate more flow out the pulmonary artery. Next, alprostadil and beta blockers keep the ductus arteriosus open. This normally closes shortly after birth to allow more blood to flow to the lungs for oxygenation. Next, we have here morphine. It relaxes the heart muscles so it can decreases cardiac while increasing the cardiac output. Next, surgical interventions. We have here intracardiac repair. It involves placing a patch over the ventricular septal defect to close the hole between ventricles. Then it repairs or replaces the narrowed pulmonary valve, which widens the pulmonary arteries to increase blood flow towards the lungs. Next, complete repair is done to improve blood flow to the lungs and to make sure that oxygen-rich and oxygen-poor blood flows to the right places. This surgery is more extensive but provides the best patient outcomes. Next, we have here Blalock-to-Sig shunt, provided mainly for care of infants who cannot tolerate extensive surgery. This procedure opens up the pulmonary artery by connecting it to the subclavian artery by means of anastomosis. It is sometimes avoided unless necessary as it may cause pulmonary artery distortion. It may be also used to improve pulmonary blood flow and oxygen saturation until the child is strong enough to tolerate a complete repair surgery. Pathophysiology of the tetralogy of Fallot. For predisposing factors, we have viral illness during pregnancy, such as rubella, a parent who has tetralogy of Fallot, genetic disorders, women older than age 40, and diabetes. For precipitating risk factors, we have alcoholism during pregnancy and poor nutrition during pregnancy. For etiology, alteration and fetal development defect includes four abnormalities. We have overriding aorta, aorta is too large, pulmonary stenosis, narrowing of pulmonary valve. Next, ventricle septal defect, prevents ventricular wall closure. And next, right ventricular hypertrophy, increased ventricular contraction from blood mixing. Decreased oxygen supply to systemic circulation. For signs and symptoms, we have cyanosis, tet spell, shortness of breath and rapid breathing, fainting, clubbing of fingers and toes, poor weight gain, tiring easily during play or exercise, irritability, prolonged crying, and heart murmur. For managements, we have nursing management, maintain oxygenation, knee chest position, or squatting to increase systemic vascular resistance and soothe child during that spell to calm them down. For medical and pharmacological management, we have prostaglandin infusion, morphine to relax the heart muscle, decreasing cardiac work and increasing cardiac output. Flow by oxygen to enhance circulating oxygen and dilate the distal pulmonary. For surgical management, we have full surgical or intracardiac repair. Next is complete removal of pulmonary valve and replaced later during school age years. Next is modified Blalock-to-Sig shunt. Here are the pictures related to tetralogy of Fallot. Nursing care plan of tetralogy of Fallot. For needs, problems, and cues, we have physiologic deficit, decreased cardiac output. For objective cues, we have cyanosis, bluish discoloration during crying, eating, being soaked in water, or tension. Next is distressed and irritable. Next is shortness of breath, rapid breathing, digital clubbing of fingers, trouble feeding and thriving, weakness and especially in the legs. Subjective cue, nakabantay ko basta mukaon siya or muhila kay maglisod siya o ginhawa, unya dali ra kaayo siya kapuyan as verbalized by the mother of the infant. For the nursing diagnosis, decreased cardiac output as evidenced by shortness of breath related to to obstruction of the right ventricle. For scientific basis, tetralogy of Fallot results in low oxygenation of blood due to mixing of oxygenated and deoxygenated blood in the left ventricle through the ventricular septal defect, and low of both oxygenated and deoxygenated blood from the ventricles, the aorta, because of the obstruction to flow through the pulmonary valve. The outflow tract of the right ventricle is obstructed due to the narrowing of the pulmonary artery. This impedes the volume of blood delivery to the lungs. As a result, systemic oxygenation levels are reduced, which causes a decrease of cardiac output. For objectives of care, after 1 week of holistic student-nurse and client interaction, the client will be able to, number 1, display stable breathing and normal levels of vital signs. Specific objective, after 8 hours of holistic student-nurse and client interaction, the client will be able to demonstrate decreased episode of dyspnea. Next, nursing actions and its rationale. Measures to decrease episodes of dyspnea and showcase hemodynamic stability. First, auscultate apical pulse, assess heart rate, rhythm, and document any significant changes. Its rationale to identify onset of unusual rhythm, tachycardia, and fine crackles in the lungs. It usually indicates heart failure. Number 2, inspect skin for any discoloration, pallor, and cyanosis. Its rationale, pallor is an indicative of diminished peripheral perfusion secondary to inadequate cardiac output. Number 3, position the baby in a knee-chest position. Its rationale, flexion of the legs provides relief of dyspnea as this angle improves oxygenation by reducing the volume of blood. Number 4, encourage and expose infant to a relaxed and calm environment. Its rationale, relaxation techniques have shown to reduce heart rate, rapid breathing, and anxiety to the infant. Number 5, perform procedures that promote sedation. Its rationale, it is necessary to sedate the child to achieve stabilization and decreases cardiac workload. 6, administer supplemental oxygen by mask or ventilator as indicated. Its rationale, increases available oxygen for myocardial uptake to combat effects of hypoxia and ischemia. Number 7, administer propranolol and phenylephrine as indicated. Its rationale, propranolol reduces pulmonary and valve spasm. Phenylephrine causes vasoconstriction and may facilitate more flow out the pulmonary artery. Number 8, emphasize the importance of cardiac rehabilitation such as regular medical checkup. Its rationale, a monitored exercise program can improve both functional capacity and heart function. It is vital to monitor the client's condition for the healthcare provider to provide immediate intervention.
Good day, I'm Kyle Kershiga, and I will be the reporter for transposition of the two great arteries. So, transposition of the two great arteries. This is the second most common congenital defect and is described as reversal of the great arteries. So, the pulmonary artery leaves the left ventricle and the aorta exits from the right ventricle with no communication between the systemic and pulmonary circulations. So the etiology or cause. So this occurs during fetal growth when your baby's heart is developing. However, the exact etiology is not completely understood because the oxygen poor blood circulates through the right side of the heart and back to the body without passing through the lungs, while the oxygen rich blood circulates through the left side of the heart and directly back into the lungs without being circulated to the rest of the body. So circulation of oxygen poor blood through the body causes the skin to have blue tint, which we call cyanosis. And because of this, transposition of the great arteries is called a cyanotic congenital heart defect. Although there are some factors such as genetics, rubella or other viral illnesses during pregnancy, maternal age over 40, or maternal diabetes. So these may increase the risk of this condition in most cases. So there are two types of transposition of the great arteries. First, we have the dextrotransposition of the great arteries or the DTGA. So DTGA, this is a heart in which the two main arteries carrying blood away from the heart are reversed. And when a detransposition occurs, the blood pathway is impaired. So this means that the blood flow cycle is stuck in either body to body or lungs to heart to body. The other one we have is the levotransposition of the great arteries, or LTGA. So a heart in which the lower section is fully reversed. This malformation of the heart causes a reversal in the normal blood flow pattern because the right and left lower chambers of the heart are reversed. So the L transposition, however, is less dangerous than the D transposition because of the great arteries are also reversed. So this double reversal allows the body to still receive oxygen-rich blood and the lungs to still receive the oxygen-poor blood. Next, we have the assessment. So first, the risk assessment. So the baby after birth infant is typically tachypneic and a murmur may not be noted. So tachypneic is a medical term when we refer to a fast, shallow breathing, which is caused by a lack of oxygen. And blood must mix to provide oxygenated blood to the system circulation. So we have prostaglandin E1 or PGE1 infusion immediately after birth. And we also have more effective mixing course through a patent form in Ovale or PFO. And we also should watch heart rate, rhythm, respiratory status, and oxygen levels. And for the signs and symptoms, again, tachypneic, the fast breathing due to low oxygen, poor feeding and growth rate, and eventually heart failure can occur. Increased heart rate, cold extremities, cyanosis, or the bluish and body and extremities due to low oxygen levels, and the increased respiratory rate. So here are the diagnostic tests to know if the baby has a TGA. So first we have the electrocardiogram. So the first picture, this records the electrical activity in the heart each time it contracts, and then we have the echocardiogram. So this confirms the diagnosis and also delineates the coronary artery anatomy. And then we have the X-ray, chest X-ray. This allows the doctor to see baby's heart size and the position of the aorta and pulmonary artery. And then we have cardiac MRI. So this may be performed to clarify some of the details of the defect. And lastly, we have the cardiac catheterization. So this is not necessary for diagnosis unless the coronary arteries cannot be visualized by the ECG or echocardiogram. So we have here's the nursing diagnosis. So first we have impaired gas exchange related to lack of oxygen to tissues as evidenced by the cyanosis because oxygen poor blood circulates through the right side of the heart and back to the body without passing through the lungs. So oxygen rich blood circulates through the heart through the left side of the heart and directly back into the lungs without being circulated to the rest of the body. So circulation of oxygen poor blood through the body causes the skin to have a cyanosis or blue tint. Next, we have the activity intolerance related to imbalance in the fulfillment of oxygen to the body's needs. So transposition of the great arteries changes the way blood circulates to the body, leaving a shortage of oxygen in blood flowing from the heart to the rest of the body. So without an adequate supply of oxygen-rich blood, the body cannot function properly and your child faces serious complications or death without treatment. Lastly, we have altered growth and development related to inadequate oxygen and nutrients to the tissues. So all cells in our body need oxygen to create energy efficiently. With TGA, there is a lack of oxygen to tissues due to oxygenated blood being circulated only to the left side of the heart in a separate circulation. So the infant's tissues will receive too little oxygen, which might cause hypoxia unless there's some mixing of oxygen-rich blood and oxygen-poor blood within the infant's body. So he or she will not grow efficiently and may not be able to survive. So next we have here the four managements. But first, nursing and medical. So for nursing interventions, nurse should watch heart rate, rhythm, respiratory status, and oxygen levels. Ensure oxygen saturation remains normal, which is 75 to 85%. Monitor signs of increased pulmonary blood flow. Support the family as they wait for their newborn to undergo heart surgery. And for medical interventions, we have after surgery, if the heart is beating too slow, a pacemaker can be used. And regular follow-up visits with a cardiologist is needed after surgery to monitor progress and avoid complications or other. So for pharmacological intervention, so the prostaglandin E1 can be administered through IV to keep the ductus arteriosus open to temporarily increase blood mixing and provide an oxygen saturation of 75% or to maintain cardiac output. For surgical interventions, we first have arterial switch procedure. So this is the procedure of choice performed in the first weeks of life. It involves transecting the gray arteries and anastomosing the main pulmonary artery to the proximal aorta just above the aortic valve, and anastomosing the ascending aorta to the proximal pulmonary artery. Next, we have the intraatrial baffle repairs. So, intraatrial baffle repairs are rarely performed, although many adolescents and adults survive today with repairs that were done more than 15 years ago. An intraatrial baffle is created to divert venous blood to the mitral valve and pulmonary venous blood to the tricuspid valve using the patient's atrial septum, or what we call sending procedure, or a prosthetic material, which is mustard procedure. Next, we have Rastelli procedure. So this procedure is the operative choice in infants with TGA, VSD, and severe pulmonic stenosis. So it involves closure of the VSD with a baffle, so left ventricle blood is directed through the VSD into the aorta. So we have here the pathophysiology of transposition of the two gray arteries, or the TGA. So for our predisposing factors, we have it could be genetic, rubella or other viral illnesses during pregnancy, as what I said earlier, maternal age over 40, and as well as maternal diabetes. For precipitating factors, we have alcoholism, smoking, and ingestion of certain drugs. And for our etiology, we have reversal of the gray arteries, oxygenated blood returns to the left atrium and left ventricle. The oxygenated blood returns to the right atrium and right ventricle, pumped to the systemic circulation, bypassing the lungs, deficient oxygen supply to the body tissues. And for our signs and symptoms, we have cyanosis, or the bluish body and extremities due to low oxygen levels, increased respiratory rate, increased heart rate, cold extremities, poor feeding and growth rate, and eventually heart failure can occur. And again, I already said nursing management, medical pharmacological, and as well as the surgical earlier. So for our nursing care plan, we have physiologic deficit, impaired gas exchange. So we have an objective cue of labored breathing, cold, clammy skin, cyanotic, vital signs of 90 over 60, 124 beats per minute, and 27 breaths per minute. So for our subjective cues, the mother asked and verbalized, I am worried about my baby's skin. It's like an abnormal skin color. Why does my baby's skin look blue? So for our nursing diagnosis, we have impaired gas exchange cyanotic related to lack of oxygen to tissues. So transposition of the gray arteries changes the way blood circulates through the body, leaving a shortage of oxygen and blood flowing from the heart to the rest of the body. Without an adequate supply of oxygen-rich blood, the body cannot function properly, and your child faces serious complications or death without treatment. For our general objective, we have after a week of holistic nursing care, the client will undergo surgical correction of arterial switch. And for specific, we have after 8 hours of nursing client interaction, the client will prepare for corrective surgery with prior care. So we have here measures taken prior to surgical correction. So for our independent intervention, we have ensure oxygen saturation remains normal, which is 75 to 85%. This is to detect any signs of decreasing oxygenation with the use of a pulse oximetry. And for dependent intervention, we have infused PGE1 or prostaglandin E1 immediately after birth as per doctor's order. So this is to maintain patency of the ductus arteriosus and encourage mixing of blood. And the next one is administer supplemental oxygen or a ventilator. So this machine helps do the work of breathing for the infant. And then we should also administer other IV medications as per doctor's order. So this, yes. And for interdependent intervention, so collaborate to support the family as they wait for their newborn to undergo heart surgery. And fifth, and this is the assurance, because assurance is important for the family to understand that surgery is required for all babies with TGA early in life, so usually within the first 14 days of life, to ensure the most positive outcomes. So now we're in the less common congenital heart defects. So again, I'm Kyle Corchega, and I will be reporting for the hypoplastic left heart syndrome, or the HLHS. So hypoplastic left heart syndrome is a rare disorder accounting for only 1 to 3% of congenital heart disease and is detectable on prenatal ultrasound. So HLHS results when there is poor or no flow to the left ventricle, typically secondary to mitral or aortic stenosis or atresia. Because of the limited amount of blood in the left ventricle, it does not develop appropriately. So the etiology or the cause is unknown. But however, if the family has one child with hypoplastic left heart syndrome, the risk of having another one with a similar condition is increased or high. For our assessment, we have our risk assessment. So assess infants, especially males, for signs and symptoms despite not being premature and no associated cardiac anomalies. So if you already have a child with this, then you have a higher risk of having another baby with similar condition. So beyond family history, there are no clear factors again for for this. And we also have to assess for signs of cyanosis and other signs and symptoms of HS, and as well as monitor oxygen saturation. For the signs and symptoms, we have babies. So babies with high HLHS may experience cyanosis or a grayish in dark-skinned people or bluish in light-skinned people discoloration of skin, lips, and nails. You also have difficulty breathing, difficulty feeding, lack of energy or lethargy, rapid heartbeat, sweaty, clammy, or cool skin, as well as weak pulse. And for diagnostic tests, we have pulse oximetry. So this non-invasive painless test measures how much oxygen is in the child's blood. So a sensor is placed on the fingertip of the child, and it records the amount of oxygen in the child's blood. So too little oxygen may mean the child has a heart or lung problem. And next we have echocardiogram. So this uses sound waves or ultrasound to create images for you or your child's heart in motion. So this allows the doctor to see the heart valves and heart muscle. And HLHS is detectable on prenatal ultrasound. Next is ECG, or the electrocardiogram. So this records the electrical activity of the heart. So written record of the electrical activity generated by the heart and provides information about heart rate, rhythm, state of myocardium, presence of or absence of hypertrophy, which means thickening of heart walls, ischemia or necrosis due to inadequate heart circulation, abnormalities of conduction, or the effect of various drugs and electrolyte imbalances on the heart. And lastly, we have cardiac MRI. So This provides a very detailed image of the heart and chest structures that are typically used as an adjunct to echocardiography. So this presents a three-dimensional image that shows the heart's abnormalities. Then we have our nursing diagnosis. So first we have deficient knowledge related to care of the child with a cardiac disorder. So because HLHS is a rare issue that accounts for only 1% to 3% of congenital heart disease, most parents are unaware of how to care for a newborn with this condition. And then next we have decreased cardiac output related to altered cardiac anatomy. So there is a decreased cardiac output related to altered cardiac anatomy since the left side of the heart is hypoplastic or underdeveloped. Lastly, we have the risk of for ineffective tissue perfusion related to impaired myocardial function. So the infant is at risk for this function since the left side of the heart is underdeveloped, which results in a cardiac output that is less than the ideal or desired functional level. Next, we have our management. So first, we have our nursing intervention. So the nurse should educate and explain the condition to newborn's parents as well as the essential treatments. And nurse should also assess for signs or symptoms of HLHS and monitor oxygen saturation because it is important to recognize and understand that a saturation of 70 to 80% is normal for children with HLHS. So for our medical intervention, so prenatal sound is done to detect HLHS. So for the follow-up care of children who have had surgical reconstruction for HLHS require a lifelong care by a cardiologist experienced in congenital heart disease. So sometimes they experience serious health problems, so many remain on medication and additional surgeries may also be required. For our pharmacological interventions, we have the PGE1 or prostaglandin E1 infusion initiated immediately after birth to keep the duct from closing. And for our surgical interventions, we have hypoplastic heart syndrome surgery. So this is an open heart surgery to redirect the oxygen blood, rich blood, and oxygen poor blood. So we have three stages of stage reconstruction. So for the stage one, we have Norwood procedure. So this surgery includes several components and it is done within a few days after birth once the child is hemodynamically stable. And next we have the bidirectional gland stunt. So this surgery usually performed at approximately 4 to 6 months of age when the child outgrows their previously placed BT or Sano shunt. And lastly, we have the stage 3 Fontan procedure. So this final stage is performed when the child weighs approximately 15 kilos or is 3 years old. And this is the pathophysiology. As what I have mentioned a while ago for the predisposing, precipitating, unknown, etiology, the signs and symptoms, and the four managements. So here is our nursing care plan. So for our problem, we have physiologic deficit, decreased cardiac output. For objective cues, we have lethargy or extreme lack of energy, and for the age of the child is less than 1 year, and it has a blue or purple tint to lips, skin, and nails. And for the vital signs, the respiratory rate is 29 beats per minute. And for the subjective cues, the mother verbalized, "Luspad lagi ni akong anak ug di sad kayo matutoy." Decreased cardiac output, blue or purple tint to lips, skin, and nails related to structural factors of congenital heart defect. So at birth, oxygen-rich blood bypasses the underdeveloped left side of the heart, going through openings between the left and right side that normally close a few days after birth. So the right side of the heart then pumps blood to the lungs and the body. Therefore, there may be no symptoms for a few days. However, when these openings close, oxygen-rich blood cannot easily get to the rest of the blood of the body, so symptoms then develop quickly. It may include problems breathing, a pounding heart, weak pulse, and or an ashen or bluish skin color. So after 1 week of holistic nursing care, the client will display hemodynamic stability before undergoing surgery, and after 8 hours of nurse client interaction, the client will demonstrate ability to tolerate activity without symptoms of dyspnea, syncope, or chest pain. So here are the measures to promote adequate cardiac output and ability to tolerate activity without symptoms of dyspnea. So first we have determine vital signs or hemodynamic parameters. This provides a baseline for comparison to follow trends and evaluate response to interventions. Next, we have evaluate response to medications administered. So this is done to determine the therapeutic adverse or toxic effects of the. And for dependent intervention, we have administer oxygen via mask or ventilator as ordered. So this is to increase oxygen available for cardiac function or tissue perfusion. And then we have administer fluids, electrolytes, diuretics, inotropic drugs, dysrhythmic, dysrhythmics, steroids, vasopressors, and or dilators as ordered. This is to support systemic and cardiac circulation as well as to minimize dehydration and dysrhythmias. And for our last interdependent intervention, we have in collaboration with specialists, discuss the condition of the family using easy to understand words. So the family needs to fully understand the condition to promote compliance to the prescribed medications.
Hi, I'm Bea Francesca Chan. I'll be discussing on tricuspid atresia or pulmonary atresia. So, tricuspid atresia, this happens when the tricuspid valve fails to develop. Consequently, there is no communication from the right atrium to the right ventricle. So, there you can see a picture. Now, for the etiology, the causes are unknown and there are no types that are applicable here. So the disease process, blood flows through an atrial septal defect or a patent foramen ova to the left side of the heart and through a ventricle or ventricular septal defect to the left ventricle and out to the lungs. So the condition is often associated with pulmonary stenosis and transposition of the great arteries. So there is complete mixing of deoxygenated and oxygenated blood in the left side of the heart, which results in systemic desaturation and varying amounts of pulmonary obstruction, which causes decreased pulmonary blood flow. Now for the assessment. For the risk assessment, screening tests are done during pregnancy as well as ultrasounds. For the signs and symptoms, we have cyanosis, tachycardia, dyspnea, and older children may have chronic hypoxemia with clubbing. Now for the diagnostic tests, a fetal echocardiogram may be requested by the doctor. So this is an ultrasound to show the structure of the heart and how the heart is working with this condition. So now we have the nursing diagnosis. So for the first nursing diagnosis, we have decreased cardiac output. So with the said condition, there will be a decrease in cardiac output since there will be inadequate blood flow to the other parts of the body due to the absence of an efficient workflow in the heart, as seen in the mixing of deoxygenated and oxygenated blood. Second, we have impaired gas exchange. So there is a deficit in oxygenation in the newborn, which is evidenced by cyanosis after birth. So when the baby is born, there is cyanosis that's present. So risk for infection. So the newborn will be going through a surgery for the early repair of the heart condition. So there is alteration of skin integrity, and considering the age of the child, he or she is prone to infections due to an immature immune system. Now for the nursing interventions, we have to note the skin color, the temperature, and moisture. Second, we have to check for peripheral pulses, including the capillary refill. Third, we have to monitor electrocardiogram or ECG for the rate, rhythm, and ectopy. Fourth, we have to position the child in semi-Fowler's position. And fifth, we have to administer oxygen therapy as prescribed. For the medical interventions, we have there is a continuous infusion of prostaglandin E1 started at 0.1 mcg per kilogram per minute until surgical intervention can be arranged. For pharmacological interventions, we have prostaglandin. So for the surgical interventions, there are 3 stages. So first we have stage 1 Norwood procedure. So this is on the first week of life. So one, we have to establish a systemic blood flow by connecting the RV to the aorta. Two, we have to rebuild a small aorta and connect to the ventricle. And third, we have to create a pulmonary blood flow either through a modified Blalock-Taussig shunt or a Sano modification. Second, there is stage 2 or bidirectional Glenn shunt. So this is from 3 to 8 months of age. So we have to create a direct connection between the superior vena cava and the pulmonary artery, allowing half of the systemic deoxygenated blood to return passively, but directly to the lungs. Third stage, we have the Fontan, which is from ages 2 to 4. So there's we have to direct a systemic return to the lungs without a ventricular pump through surgical connections between the right atrium and the pulmonary artery. So a fenestration is sometimes made in the right atrial baffle to relieve pressure. Here we have the pathophysiology. So for the predisposing factors, we have poorly controlled diabetes, Down syndrome, and third, a parent who had a congenital heart defect. For the precipitating factors, we have viral disease during early pregnancy. Second is too much alcohol during pregnancy. And third, took medications such as anti-seizure or anti-acne during pregnancy. So its etiology, causes are unknown. So it could lead to the tricuspid valve fails to develop. Consequently, there is no communication from the right atrium to the right ventricle. So that we have the signs and symptoms, the cyanosis, tachycardia, dyspnea, and older children may have chronic hypoxemia with clubbing. So we have the interventions that were mentioned from earlier. Now, for the nursing care plan, we have the needs, problems, and cues. So this is a physiologic problem. So decreased cardiac output with objective cues, tachycardia, clammy skin, and ECG changes with objective cues, heart palpitations, dyspnea, and lethargic. So for the nursing diagnosis, we have decreased cardiac output related to cyanosis at birth. So for the scientific basis, we have reduced cardiac output in heart failure and shock can lead to peripheral cyanosis if severe. Lack of pressure prevents an adequate supply of oxygen-rich blood to the extremities. Also, hypotension produces reflex cutaneous vasoconstriction to shunt blood from extremities to the internal organs. So this redistribution of blood flow from extremities causes cyanosis of extremities. So for the objectives of care, you have the general objective. So after 1 week of holistic nursing care, the client will be able to display hemodynamic stability. For the specific objectives, we have after 8 hours of student nurse-client interaction, the client's guardian will be able to 1. Report decreased episodes of dyspnea, and 2. Seek help appropriately. So for the nursing actions, we have measures to identify causative factors and minimize causative factors. So 1, we have to determine the vital signs and hemodynamic parameters, including cognitive status. So this provides a baseline for comparison to follow trends and evaluate response to the interventions done. Second, we have to review laboratory data, including but not limited to CBC, electrolytes, arterial blood gases, cardiac biomarkers, and etc. So this is to identify the client at risk and promote early intervention. Third, we have to review diagnostic studies, including but not limited to chest radiograph, cardiac stress testing, electrocardiogram, and echocardiogram. So this is done to determine whether the condition is evolving or is managed well. 4, we have to observe for reports of chest pain. We have to note its location, its intensity, characteristics, and radiation of pain. So this may indicate an evolving heart attack. So we have to be careful and observe closely for this. 5th, we have to administer oxygen via mask or ventilator as indicated. So this is to increase oxygen available for cardiac function and tissue perfusion. So the reference for these interventions were taken from the Handbook of Nursing Diagnosis. Next, I'll be discussing on the truncus arteriosus. So this condition, this is the failure of the normal septation and division of the embryonic bulbar trunk into the pulmonary artery and the aorta, which results in the development of a single vessel that overrides both the ventricles. Now, its cause is unknown. So for the types, we have three. Type 1, so this is a singular or a single pulmonary trunk arises near the base of the truncus and divides into the left and right pulmonary arteries. Type 2, we have the left and right pulmonary arteries arise separately but in close proximity and at the same level from the back of the truncus. And type 3, we have the pulmonary arteries arise independently from the sides of the truncus. Now, for the disease process, so blood is ejected from the left and right ventricles, which then enter the common trunk, so pulmonary and systemic circulations are mixed. Blood flow is distributed to the pulmonary and systemic circulations according to the relative resistances of each system. So pulmonary vascular disease develops at an early age in patients with truncus arteriosus. So pulmonary vascular disease is associated with this condition. Now, for the risk assessment, we have prenatal tests and ultrasounds. For the signs and symptoms, we have moderate to severe heart failure, variable cyanosis, poor growth, as well as activity intolerance. Now, for the diagnostic tests, we have So, for the nursing diagnosis, we have decreased cardiac output related to heart defects. So arteries are the vessels that transport oxygenated and non-oxygenated blood to and from the heart and towards the lungs and the rest of the body. So with a congenital heart disease, there is an insufficient blood flow to the rest of the body. Now, second, we have the compromised family coping related to baby's development crisis. So, not all families cope well with news that may be brought about with the birth of a newborn with congenital heart defects. Third, we have the risk for infection related to surgery wound. So, congenital heart diseases may require surgeries to lengthen the lifetime of a newborn and to better manage the health of the newborn. So, as young as a newborn, there is less resistance to infections. Third, for this segment, we have the management. So for the nursing management, first we have to note the skin color, temperature, and moisture. Second, we have to check for peripheral pulses, including the capillary refill time. Third, we have to monitor electrocardiogram or ECG for the rate, rhythm, and ectopy. Fourth, we have to position the child in semi-Fowler's position. And fifth, we have to administer oxygen therapy as prescribed. Now, for the medical interventions, we have the pulse oximetry screening. So, oxygen saturation should measure greater than or equal to 95%. Second, we have to perform fetal echocardiogram. For the pharmacological intervention, we have to administer with the order of the physician digoxin or lanoxin, alprostadil or Prostin VR pediatric, furosemide Laxix, or spironolactone aldactone. For the surgical interventions, we have the Rastelli repair and cardiac catheterization. Now here for the pathophysiology, we have the predisposing factors, poorly controlled diabetes, certain chromosomal disorders, and obesity. For the precipitating factors, we have viral illnesses such as rubella, certain medications taken during pregnancy, smoking, and alcohol use. So the etiology, results of the great artery failing to divide into in utero into two vessels, in the pulmonary artery and the aorta. So this is the failure of normal septation and division of the embryonic bulbar trunk into the pulmonary artery and the aorta, which results in development of a single vessel that overrides both ventricles. So we have the signs and symptoms, the moderate and to severe heart failure, the variable cyanosis, poor growth, and activity intolerance. Now, below those, you can see the interventions that were just mentioned before the pathophysiology was mentioned. So now we have the nursing care plan. We have the risk problem, infection, and the risk factor as the alteration in skin integrity. So, nursing diagnosis, the risk for infection related to surgery. Now, for the scientific basis, infections after surgery are caused by germs. So, the most common of these include the bacteria Staphylococcus, Streptococcus, and Pseudomonas. So, germs can infect a surgical wound through various forms of contact, such as from the touch of a contaminated caregiver surgical instrument, through germs in the air, or through germs that are already on or in your body and then spread into the wound. So for the objectives of care, we have general objective. After 1 week of holistic caring care, the client's guardian will be able to identify interventions to prevent or reduce the risk or infection. Specific objective, we have after 8 hours of student-nurse-client interaction, the client's guardian will be able to demonstrate techniques and lifestyle changes to promote safe environments. So for the nursing actions, we have measures to assess contributing factors and reduce existing factors. So one is the extremes of age. So newborns are more susceptible to disease and infection than the general population because of the maturity of their immune system. Second, we have the presence of underlying disease. So the client may have prolonged disease conditions that may weaken the immune system. Third, trauma. So the loss of skin and tissue integrity and surgery, among the others, are common paths for pathogen entry. Fourth, we have observed for changes in skin color and warmth at insertion sites of invasive lines, sutures, surgical incisions, and wounds. So this could be signs of a developing localized infection. Fifth, we have to observe changes in mental status.
Good day everyone, this is Mary Janine Caballas, and today I will be reporting about total anomalous pulmonary venous return. Total anomalous pulmonary venous return is a heart disease in which the four veins that may take blood from the lungs to the heart do not attach normally to the left atrium, left upper chamber of the heart. For its etiology, the cause is unknown. For its types, supracardiac, the pulmonary vein come together and form an abnormal connection above the heart to the superior vena cava. Second, cardiac, the pulmonary vein meet behind the heart and connect to the right atrium. Third, infracardiac, the pulmonary vein come together and form abnormal connections below the heart. Disease process. The right atrium receives both blue blood from the body and red blood from the lungs. As a result, the right side of the heart is overworked from pumping the extra blood it receives. Frequently, there is a blockage to the vein that receives blood from the pulmonary vein, which causes a backup of blood in the lungs. This disrupts the normal flow of blood between the lungs and the body. Additionally, the blood leaving the heart from the body has a lower level of oxygen. For assessment, for its risk assessment, genes and chromosomes, ultrasound, electrocardiogram, newborn pulse, oximetry screening. For its signs and symptoms, cyanosis, problem breathing, heart murmur, weak pulse, fast heart rate, for feeding, extreme sleepiness, weakness, rapid breathing, retractions of the rib, a large liver, cool, clammy skin. For diagnostic test, number 1, chest x-ray, may show changes in the heart and lungs caused by TAPVR. For ECG, it records the electrical activity of the heart. It also shows abnormal rhythms and detects heart muscles, stress, and these problems may cause by TAPVR. Echocardiogram. This test uses sound waves to make a moving picture of the heart and heart valves. An echo can show the structural changes of the APVR. Cardiac catheterization. Cardiac catheterization gives detailed information about the structures in the heart. In this test, a small, thin, flexible tube is put into blood vessels in your child's groin. For MRA, A CT and MRA can show detailed information about the pathways and connections of the pulmonary vein. For nursing diagnosis, first we have decreased cardiac output. For its rationale, cardiac output is the amount of blood pumped by the heart per minute. It is the product of the heart rate, which is the number of beats per minute, and the stroke volume, which is the amount of pump per beat. Second, activity intolerance. First, rational. Activity intolerance is a diagnostic judgment that describes an individual with compromised physical conditioning. This individual can engage in therapies to increase strength and endurance. Third, risk for injury. Congenital heart disease results from malformations of the heart that involve the septums, valves, and large arteries. They are classified as cyanotic or cyanotic defects. For its management, first nursing interventions, assess the heart rate and blood pressure, monitor electrocardiogram for rate, rhythm, and ectopy. Administer oxygen therapy as prescribed. Allow for periods between care, disturb only when necessary for care and procedures. Assist patients to plan for care and rest schedules. Monitor orders for diagnostic tests and procedures. For medical interventions, supplemental oxygen or a machine that allows breathable air to move in and out of the lungs. Mechanical ventilation, ECMO or extracorporeal membrane oxygenation. For its pharmacological intervention, prostaglandin therapy. This medicine is used to keep the ductus arteriosus open and allow blood to flow through the heart. This medicine isn't used in some types of the APVR. For surgical intervention, the APVR surgery is done through an incision through the sternum and into the chest. The baby will be connected to a heart-lung machine during surgery. Its pathophysiology. For predisposing factors, genetic mutation, chromosome 4, SEMA3D mutation. For precipitating risk factors, not getting enough folic acid, drinking alcohol during pregnancy, smoking, and obesity. For its etiology, no exact etiology. Problem in the usual connection between the blood vessels coming from the lungs to the left atrium. Blood vessels coming from the lungs connect with the right atrium instead of left. Blood vessels from lungs drain into another blood vessels, eventually drains to the right atrium. Too much blood flow into the lungs. Blood vessels of the lungs become compressed. Blood vessels that goes out to the body has less oxygen. For its signs and symptoms, cyanosis, fast heart rate, rapid trouble breathing, heart murmur, cool or clammy skin, poor feeding, and weakness and little movement. For its nursing management, assess heart rate and blood pressure, monitor ECG rate and rhythm and ectopy, assist parents to plan for care and rest schedules. Lastly, monitor orders for diagnostic tests and procedures. For its pharmacologic and medical management, prostaglandin therapy, supplement oxygen, mechanical ventilation, ECMO or extracorporeal membrane oxygenation to provide both cardiac and respiratory support. For surgical management, the APVR surgery is done through an incision through the sternum and into the chest. The baby will be connected to a heart-lung machine during surgery. This device does the work of your baby's heart and lungs during surgery. For its nursing care plan, physiologic deficit, decreased cardiac output. For its objectives of cues, we have here respiratory rate 70 breaths per minute, heart rate 160 ppm, heart murmur, and cyanosis. For its nursing diagnosis, decreased cardiac output, arrhythmias related to structural factors of congenital heart defect. Scientific basis: in a baby with DAPVR, oxygen-rich blood does not return from the lungs to the left atrium. Instead, the oxygen-rich blood returns to the right side of the heart. Here, oxygen-rich blood mixes with oxygen-poor blood. This causes the baby to get less oxygen than it's needed to the body. Objectives of care. General objectives. After 1 week of holistic nurse-newborn interaction, the child will be able to demonstrate adequate cardiac output. Specific objectives. After 8 hours of holistic nurse-client interaction, the child will be able to exhibit a pulse rate within the normal levels for the patient, exhibit normal heart rhythms, and for the nursing actions, measures to improve cardiac output for independent, note skin, color, temperature, and moisture. For its rationale, cold, clammy, and pale skin and is secondary to a compensatory increase in sympathetic nervous system stimulation and low cardiac output and oxygen desaturation. Second, check for peripheral pulses including capillary refill. For rational, weak pulses are present in reduced stroke volume and cardiac output. Capillary refill is sometimes low or absent. Third, inspect fluid balance and weight gain. Weigh patients regularly prior to breakfast. For its rational, compromised regulatory mechanisms may result in fluid and sodium retention. Fourth, provide adequate rest periods. For its rational, rest decreases metabolic rate, decreasing myocardial and oxygen demand. For dependent, provide prostaglandin therapy as ordered. This medicine is used to keep the ductus arteriosus open and allow blood to flow through the heart. This medicine isn't used in some types of the APVR. Sixth, provide supplemental oxygen. For its rational, a machine that allows breathable air to move in and out of the lungs. This helps with breathing. For interdependent, refer to a cardiologist, and this will provide further information regarding your situation. Hey everyone, this is Mary Jeannie Caballos, and today I will be reporting about rheumatic fever. Rheumatic fever is inflammation of the joints, heart, skin, and nervous system resulting from a complication of untreated streptococcal infection of the throat. Rheumatic fever can occur at any age but occurs most often between ages 5 years and 15 years. Rheumatic fever can cause permanent damage to the heart, which is rheumatic heart disease. It usually occurs 10 to 20 years after the original illness, but severe cases of rheumatic fever can cause damage to the heart valves while your child has still symptoms. Rheumatic fever can occur after throat infection from a bacteria called Group A beta hemolytic streptococcal pharyngitis. Group A streptococcus infections from the throat cause strep throat or less commonly scarlet fever. Its disease process, the organism attached to the epithelial cells of the upper respiratory tract and produce a battery of enzymes which allows them to damage and invade human tissues. After an incubation period of 2 to 4 days, the invading organisms elicit an acute inflammatory response with 3 to 5 days of sore throat, fever, headache, and elevated leukocyte count. In a small percentage of patients, infection leads to rheumatic fever several weeks after a sore throat has resolved. For assessment, for its risk assessment, 1. Rapid antigen detection test, anti-streptococcal antibodies, acute phase reactants, heart-reactive antibodies, rapid detection test for D8/17, or chest radiography. For its signs and symptoms, 1. We have fever, painful and tender joints, most often in the knees, ankles, elbows, and wrist. Pain in one joint that migrates to another joint. Red, hot, or swollen joints. Subcutaneous nodules, small, painless bumps beneath the skin. Chest pain, heart murmur, and fatigue. For diagnostic tests, we have throat culture. For throat culture for GABHS infections, usually are negative by the time symptoms of rheumatic fever or rheumatic heart disease appear. Make attempts to isolate the organism prior to the initiation of antibiotic therapy to help confirm a diagnosis of streptococcal pharyngitis and to allow typing of the organism if it is isolated successfully. For blood tests that can detect antibodies to the strep bacteria in the blood is done. The actual bacteria might no longer be detectable in the child's throat tissues or blood. For electrocardiogram, which is ECG, this test records the electrical signals as they travel through your child's heart. These results can tell if the electrical activity of the heart is abnormal and can help your doctor determine if parts of the heart may be enlarged. For echocardiogram, sound waves are used to create live action images of the heart, which can help your doctor detect your heart problems. Jones criteria, low risk populations. Major and minor criteria are as follows. For major criteria, we have carditis, clinical and or subclinical, arthritis, polyarthritis, chorea, erythema marginatum, subcutaneous nodules. And for minor criteria, we have polyarthralgia, fever, which is greater or equivalent to 38.5 Fahrenheit, sedimentation rate of greater than or equivalent to 60 mm and or C-reactive protein CRP greater than or equivalent to 3.0 mg or DL. Prolonged PR interval unless carditis is a major criterion. For Jones criteria, moderate and high-risk populations, major and minor criteria are as follows. For major criteria, we have carditis, clinical and or subclinical, arthritis, monopolyarthritis or polyarthralgia, chorea, erythema marginatum, subcutaneous nodules. For minor criteria, we have fever, greater than or equivalent to 38.5 Fahrenheit, sedimentation rate is greater than or equivalent to 30 mm and or CRP greater than or equivalent to 3.0 mg or DL. Prolonged PR interval unless carditis is a major criterion. Diagnosis, we have first, acute pain may be related to changes in vital signs. First, rational. These vital signs can be affected by pain in several ways. For example, a normal response to pain is an increase in heart rate, breathing rate, and blood pressure. Abnormal vital signs can be an indication that pain is severe and is harming your health. Second, hyperthermia may be related to possibly evidenced by increased body temperature. Hyperthermia is defined as elevated body temperature due to a break in thermoregulation that arises when a body produces or absorbs more than and it is dissipates. It is a sustained core temperature beyond the normal variance, usually greater than 39 degrees Celsius. And third, risk for decreased cardiac output possibly evidenced by risk factors of altered contractility. Decreased cardiac output may result in insufficient blood supply and compromised vital reactions. This can result in transition towards anaerobic metabolic pathways which lead to production of lactic acid, reduced cellular pH, enzyme denaturation, and altered membrane potential. For management, nursing interventions, provide comfort and reduce pain, position the child to reduce joint pain, warm baths, and gentle range of motion exercises to help alleviate some of the joint discomforts. Provide diversional activities and sensory stimulation. For those who do not feel very ill, bed rest can cause distress or resentment. Promote energy conservation. Provide rest periods between activities to help pace the child's energies and provide for maximum comfort. Prevent injury. Protect the child from injury by keeping the side rails up and padding them. For medical interventions, therapy is directed towards eliminating the GABHS pharyngitis, if still present, suppressing inflammation from the autoimmune response, and providing supportive treatment of congestive heart failure. Advise nutritious diet with restriction except in patients with CHF. Initially place the patients on bed rest, followed by a period of indoor activity. For pharmacological antibiotics, penicillin or another antibiotic to eliminate remaining strep bacteria, anti-inflammatory treatment. A pain reliever like aspirin or naproxen to reduce inflammation, fever, and pain. If symptoms are severe or the child's not responding to the anti-inflammatory drugs, then corticosteroid may be prescribed. Anticonvulsant medication for severe involuntary movements, example, valproic acid. For surgical, when heart failure persists or worsens after aggressive medical therapy for acute RHD, surgery to decrease valve insufficiency may be life-saving. Approximately 40% of patients with acute rheumatic fever, subsequently develop mitral stenosis as adults. Pathophysiology, predisposing factors, immunocompromise, genetic variants that implicate susceptibility. Precipitating risk factors, we have overcrowding, poor sanitation, poverty, reduced access to medical care. For its etiology, caused by bacterium called group A, Streptococcus, and this bacterium causes strep throat, or in a small percentage of people, scarlet fever. It's an inflammatory disorder. The organisms attach to the epithelial cells of the upper respiratory tract and produce a battery of enzymes which allows them to damage and invade human tissues. After an incubation of period of 2 to 4 days, the invading organisms elicit an acute inflammatory response, with 3 to 5 days of sore throat, fever, malaise, headache, and elevated leukocyte count. Direct contact with oral or respiratory secretion transmits the organism in crowded and enhances transmission. Patients remain infected for weeks after symptomatic resolution of pharyngitis and may be reservoir for infecting others. Signs and symptoms: fever, painful and tender joints, red, hot, or swollen joints, subcutaneous nodules, chest pain, heart murmur, chorea, and fatigue. For nursing management, provide comfort and reduce pain, provide diversional activities and sensory stimulation, promote energy conservation, and prevent injury. Pharmacologic and medical management, advise nutrition diet, initially place patient on bed rest followed by a period of indoor activity, antibiotics, anti-inflammatory treatment, aspirin, anticonvulsant medication, valproic acid, or carbamazepine. Surgical management, when heart failure persists or worsens after aggressive medical therapy for acute RHD, surgery to decrease valve insufficiency may be life-saving. Approximately 40% of patients with acute rheumatic fever subsequently develop mitral stenosis as adults. For its nursing care plan, we have physiologic overload, which is acute pain. For its objective cues, redness, warmth and affected joints, guarding and protective behavior of painful joints. For its nursing diagnosis, acute pain, warm and at affected joints related to inflammation, secondary to rheumatic fever. For its scientific basis, a symptom of rheumatic fever is painful, tender joints, or just arthritis, most commonly in the knees, ankles, elbows, and wrist. Arthritis or pain and swelling in the joints affects 75% of patients. It normally starts in the larger joints, such as the knees, ankles, wrists, and elbows, before moving to other joints. This inflammation normally resolves within 4 to 6 weeks without causing permanent damage. For its objectives of care, for its general objective, after 1 week of holistic nurse-newborn interaction, the child will be able to appear relaxed without pain. Specific objective, after 8 hours of holistic nurse-client interaction, the child will be able to display joints that are no longer inflamed, red, or warm, and exhibit less guarding and protective behavior. For its nursing intervention, measures to reduce pain. For its independent, examine the affected joint's degree of the joint pain, level of joint movement. For its rational, provides data about pathologic changes in joints, reversible joint involvement, usually affecting large joints such as knees, hips, wrists, and elbows. An increase in numbers of affected joints occur over a period of time. 2. Elevate involve extremities above heart level. It's for its rational, improve circulation to the heart to alleviate the edema. Third, reassure patients or parents and the child the joint involvement is temporary, that pain and edema will subside, and that joints will return to normal size. For its rational, reduces anxiety related to fear of irreversible damage. Fourth, provide measures to relieve pain before it becomes severe. For its rational, it is preferable to provide an analgesic before the onset of pain or before it becomes severe, when a larger dose may be required. For dependent, provide anti-inflammatory treatment. For its rational, relieves pain, inflammation in joints, and provides rest and comfort. 7th, acknowledge and accept the client's pain. For its rational, nurses have the duty to ask their clients about their pain and relieve the reports of pain. Challenging or undermining their pain reports results in an unhealthy therapeutic relationship that may hinder pain management and deteriorate rapport. Performing nursing care during the peak effect of analgesics. Performing nursing tasks during the peak effect of analgesic optimizes client comfort and compliance in care. 9. Evaluate the effectiveness of analgesic as ordered and observe for many signs and symptoms of side effects. For its rationale, the patient's effectiveness of pain medications must be evaluated individually since they are absorbed and metabolized differently. For interdependent, contact physician to schedule a cognitive behavioral therapy. For its rationale, these methods are used to provide comfort by altering physiological responses to pain.
Good day everyone, I am Jari Doizel Alerta and I will be reporting infectious endocarditis. Infectious endocarditis is an infection of the valves and inner lining of the heart, which can potentially damage or destroy the heart valves with high morbidity and mortality for affected patients. Although it can occur without underlying heart disease, it most often is a sequela of bacteremia in children with congenital anomalies of the heart or great vessels. It especially affects children who have undergone surgery to repair or palliate complex cyanotic heart defects, valvular abnormalities, prosthetic valves, conduits, ventricular septal defects, patent ductus arteriosus, tetralogy of Fallot, or sequela of rheumatic heart disease with valve involvement. Children with indwelling catheters are also at risk. Endocarditis can also occur without any known risk factors, commonly affecting the mitral or aortic valve. The incidence of it appears to have increased in the pediatric and neonatal population, most likely due to improved survival among children at risk for BE or those with congenital heart defects and hospitalized infants. So the most common causative agents are Streptococcus viridans and Staphylococcus aureus. Gram-negative bacteria, Enterococcus, and fungi such as Candida albicans are also causes of it. There are two infectious endocarditis. We have acute infective endocarditis and subacute infective endocarditis. For the acute infective endocarditis, it is destructive infection affecting a previously normal heart valve caused by highly virulent organisms and leads to death within days to weeks in 50% of patients. For the subacute, it is an infection of a previously diseased heart caused by a low virulence organism. It is an insidious onset, which course of weeks to months, and most patients recover with therapy. So the microorganisms in IE usually grow on a section of the endocardium that has been subjected to abnormal blood streaming and turbulence, such as occurs when blood flow is restricted by an anatomic narrowing or forced through an abnormal opening. Growth may also begin where the abnormal jet of blood strikes the opposing endocardium, causing thickening of the lining or damage to the valvular endothelium. Changes in the endocardium predispose it to the deposition of platelets and fibrin and ultimately make the area susceptible to the growth of invading organisms. Organisms may enter the bloodstream from any site of localized infection. Transient bacteremia also occurs with trauma to mucosal surfaces encountered in normal daily activities, such as brushing, flossing gums, and chewing. The microorganisms grow on the endocardium, forming vegetations. The lesion may grow to invade adjacent tissues such as aortic and mitral valves and myocardium, and may break off and embolize elsewhere, especially in the spleen, kidney, central nervous system, lung, skin, and mucous membranes. For the assessment, first we have risk assessment. For the physical examination, we have vital signs. A fever will likely be present, rigors may be also present, and some patients may have a wide pulse pressure due to aortic insufficiency. If the pulse pressure narrows, this may be a sign of left ventricular failure due to earlier closure of the mitral valve and a more rapid rise in the left ventricular and diastolic pressure, which will in turn raise the diastolic pressure. For the skin, petechiae are present in 10% to 40% of patients. Splinter hemorrhages are also present in 5% to 15% of the patients. Osler's nodes, which are tender subcutaneous nodules in pulp of digits, are present in 7% to 10% of patients. Janeway lesions, which are erythematous non-tender lesions on palm or sole, are also present in 6% to 10% of patients. For the oral cavity, examine the oral cavity with poor oral hygiene, teeth looking for periodontitis, plaque and calculus, gingiva looking for gingivitis, and recent dental procedure. Next is HEENT, conjunctival hemorrhage, rots, spots in the retina, and bubbling of the uvula may be present among patients with new onset aortic regurgitation. For the lungs, there is signs of heart failure such as rales may present. For the heart murmurs are present in 80% to 85% of patients, including that of aortic insufficiency, tricuspid regurgitation, and mitral regurgitation. For the abdomen, abdominal pain may be present due to mesenteric embolization or ileus, both of which may manifest as reduced bowel sounds. Splenomegaly may be present in 15% to 30% patients. Left upper quadrant pain may be present as a result of a splenic infarct from embolization. Flank pain may also be present as a result of an embolus to the kidney. For neurologic, septic emboli may result in stroke and focal neurologic findings. Seizures may be also present. Intracranial hemorrhage may occur, and signs of a brain abscess may be present. For the extremities, we have again the Janeway lesions, which is a painless hemorrhagic cutaneous lesions on the palms and soles. Then gangrene of fingers may occur, and the fingers may show splinter hemorrhages and Osler's nodes, which are painful subcutaneous lesions in the distal fingers. Lastly, we have the patient's history. So patients with endocarditis may have a positive history of any congenital heart disease, valvular heart disease, intravenous drug abuse, prosthetic heart valves, intracardiac devices, immunosuppression, poor dental health, and history of recent dental procedures, lupus, and malignancy. For the signs and symptoms, so according to the book, we have fever, malaise, new murmur, and the findings of vegetations or verrucae on echocardiography. For the diagnostic test, we have echocardiogram to view the valves and blood flow through your heart, transesophageal echocardiogram for more detailed view of the heart from the esophagus, blood tests and cultures to check for bacteria and signs of inflammation, ECG or electrocardiography to analyze your heart rhythm, chest x-ray to examine your lungs, cardiac CT if more information is needed about your heart, urine test to check for kidney damage, and MRI of the brain to check for damage. For the nursing diagnosis, we have here a 3 priority nursing diagnosis with each rationale. So for the first one, we have imbalanced nutrition less than body requirements related to anorexia as evidenced by loss of weight. So malnutrition is highly associated with infections and impaired immunity with increased susceptibility to microorganisms, and it can be expected to lead to more severe cases of infectious endocarditis. Next is decreased cardiac output related to valvular insufficiency and fluid overload as manifested by a heart murmur and tachycardia. So the heart fails to pump enough blood to meet the metabolic needs of the body. The blood flow that supplies the heart is also decreased. Therefore, decrease in cardiac output occurs. Blood then is insufficient and making it difficult to circulate the blood to all parts of the body, thus may cause altered heart rate and rhythm and weakness. Lastly, we have fever related to infection of cardiac tissue as manifested by increased temperature, diaphoresis, chills, headache, and malaise. So fever is a complex physiological response to infection, inflammation, and tissue injury, which many organisms have the ability to produce by altering their internal thermostat. The commonest cause of fever was extensive infection of the valve ring and adjacent structures even when the infecting organisms were virulent streptococci. So for the managements, first we have the nursing actions. First is preparation of the child for IV infusion, usually with an intermittent infusion device and performance of several venipunctures to draw blood for culture and laboratory values. Use of sterile technique when administering IV antibiotics. Observation for side effects of antibiotics, especially inflammation along venipuncture sites, along with assessments of renal function. Observation for complications including embolism and heart failure. And lastly, education regarding the importance of follow-up visits for cardiac evaluation, echocardiographic monitoring, and blood culturing. For the medical interventions, first is to perform blood cultures periodically to evaluate the response to antibiotic therapy. As soon as the blood cultures have been secured, the patient is started on intravenous antibiotic therapy to broad spectrum, covering as many as possible of suspected bacterial species. Then monitor symptoms throughout therapy and blood cultures are repeated to determine the effectiveness of treatment. Lastly, if the patient is having poor intake of oxygen, administer oxygen therapy 4 to 6 lm in helping the patient get supplemented with enough oxygen. For the pharmacological interventions, first is administration of high-dose antibiotics given intravenously for 2 to 8 weeks to completely eradicate the infecting microorganism. And high-risk patients involves administration of prophylactic antibiotic therapy 1 hour before dental procedures. For the surgical interventions, valvectomy and valve replacement are performed to remove infected tissue and restore hemodynamic function. Now we have here the pathophysiology of the infectious endocarditis. For the predisposing factors, we have IV drug abuse, history of endocarditis, immunocompromise, artificial heart valves, and congenital heart defects. For the precipitating factor, poor dental health. So, etiology, the majority of cases of infectious endocarditis are due to bacteria. The most common causative agents are Streptococcus viridans and Staphylococcus aureus. Gram-negative bacteria, Enterococcus, and fungi such as Candida albicans are also causes of infectious endocarditis. Acute bacterial endocarditis is caused by an infection with a virulent organism such as Staphylococcus aureus, Group A or other beta hemolytic streptococci. Subacute bacterial endocarditis is an indolent infection with less virulent organisms such as Streptococcus viridans. The pathogenesis of infectious endocarditis includes valvular damage, altered and turbulent flow, bacteremia, and lack of blood supply to the valves. Damaged endothelium becomes a site for attachment of infectious agents i.e., the characteristic lesion of endocarditis is vegetation. Vegetations are composed of fibrin, inflammatory cells, platelets, and microorganisms. For the signs and symptoms, we have fever, malaise, new heart murmur, Osler's nodes, Janeway lesions, and Roth spots. So for the managements, first we have the nursing actions. First is preparation of the child for IV infusion, usually with an intermittent infusion device and performance of several venipunctures to draw blood for culture and laboratory values. Use of sterile technique when administering IV antibiotics. Observation for side effects of antibiotics, especially inflammation along venipuncture sites, along with assessments of renal function. Observation for complications including embolism and heart failure. And lastly, education regarding the importance of follow-up visits for cardiac evaluation, echocardiographic monitoring, and blood culturing. For the medical interventions, first is to perform blood cultures periodically to evaluate the response to antibiotic therapy. As soon as the blood cultures have been secured, the patient is started on intravenous antibiotic therapy to broad spectrum, covering as many as possible of suspected bacterial species. Then monitor symptoms throughout therapy and blood cultures are repeated to determine the effectiveness of treatment. Lastly, if the patient is having poor intake of oxygen, administer oxygen therapy 4 to 6 lm in helping the patient get supplemented with enough oxygen. For the pharmacological interventions, first is administration of high-dose antibiotics given intravenously for 2 to 8 weeks to completely eradicate the infecting microorganism. And high-risk patients involves administration of prophylactic antibiotic therapy 1 hour before dental procedures. For the surgical interventions, valvectomy and valve replacement are performed to remove infected tissue and restore hemodynamic function. For our nursing care plan, we have decreased cardiac output, subjective cues, chest pain, and symptoms of heart failure. Objective cues, heart murmurs, tachycardia, temperature elevation, and decreased oxygen saturation. Nursing diagnosis, decreased cardiac output related to valvular insufficiency and fluid overload as manifested by a heart murmur and tachycardia. Scientific basis. Infective endocarditis is caused by a pathogen, either bacterial, viral, or fungi. The microbes come from another body part, such as the mouth, skin, intestines, or the urinary tract, and can spread through the bloodstream and reach the damaged cardiac tissues. A person with existing cardiac issues is more susceptible to endocarditis than someone who has a healthy heart. Objectives of care. For the general objectives, after 1 week of holistic nursing care, the client will be able to maintain adequate cardiac output. For the specific objectives, after 4 hours of nurse-client interaction, the client will first, maintain normal body temperature, relieve the signs and symptoms of the disease, and report an increase in physical and emotional comfort. Nursing interventions. These measures to maintain adequate tissue and organ perfusion. For our independent nursing intervention, we have elevate head of bed. This is to reduce O2 demand. Second, educate patient on stress management, deep breathing exercises, and relaxation techniques. Stress causes a persistent increase in cortisol levels, which has been linked to people with cardiac issues. Chronic stress may also cause an increase in adrenaline levels, which tend to increase the heart rate, respiratory rate, and blood sugar levels. Reducing stress is also an important aspect of dealing with fatigue. For our dependent nursing intervention, administer the antibiotics as prescribed. Antibiotics will treat the bacterial infection that caused the endocarditis. Then administer supplemental oxygen as prescribed. Discontinue if oxygen saturation level is above the target range or as ordered by the physician. This is to increase the oxygen level and achieve an oxygen saturation value of at least 94%. For our interdependent nursing intervention, we have provide the patient and family with emotional support and facilitate coping strategies. Endocarditis is treated with long-term courses, so each course can last as long as 6 weeks. So by providing emotional support, this will improve the healing process and help patient feel safe and more empowered with managing their own recovery. Now let's move on to the Kawasaki disease. So Kawasaki disease or mucocutaneous lymph node syndrome is a febrile multisystem disorder that occurs almost exclusively in children before the age of puberty. It has replaced rheumatic fever as the most likely cause of acquired heart disease in children. The peak incidence is in boys under 4 years of age. The incidence is higher in late winter and spring. Vasculitis or inflammation of blood vessels is the principal and life-threatening finding because it can lead to formation of aneurysm and myocardial infarction. The etiology of Kawasaki disease remains unconfirmed. Although it is not spread by person-to-person contact, several factors support an infectious cause or trigger. KD is often seen in geographic and seasonal outbreaks, with most cases reported in the late winter and early spring. It is also a pediatric illness, which suggests the development of passive immunity, because an etiologic agent has not been found. Some experts believe that the illness may represent a final common pathway triggered by an infectious agent or more than one potential agent. Two-thirds of patients report having had at least one GI symptom, and over one-third report respiratory symptoms in the 10 days prior to the onset of Kawasaki disease. Some recent studies have focused on genetics, trying to ascertain why some children are more likely to get Kawasaki disease than others. The possibility that the illness represents a final common pathway in a genetically susceptible host. The disease process of Kawasaki disease involves widespread inflammation of the small and medium-sized blood vessels, with the coronary arteries being the most susceptible to damage. During the acute stage of the illness, there is progressive inflammation of those small vessels, which are the capillaries, venules, arterioles, along with pancarditis. This inflammation is reflected in the clinical signs and symptoms and in laboratory test results. Inflammatory markers or C-reactive protein level and erythrocyte sedimentation rate are elevated in the acute illness. The vasculitis can progress to the medium-sized muscular arteries, potentially damaging the walls of the vessels and leading to the formation of coronary artery aneurysms in some children. Initial evidence of enlargement of the coronary arteries by echocardiogram can be detected as early as day 7 of illness. Affected vessels can continue to enlarge for several weeks and generally reach their largest diameter approximately 4 to 6 weeks from the onset of fever. Longer duration of fever, or most likely reflecting the severity of inflammation, is strongly associated with the development of aneurysms. Aneurysms of the peripheral vessels, axillary, brachial, iliac, cervical, and renal arteries can occur. Although this is rare and usually is seen only in children who also have giant coronary aneurysms. In the acute phase, myocarditis or inflammation of the myocardium is common. Decreased LV function may be evident on echocardiogram. However, the majority of children do not have clinical signs of heart failure. Ventricular function usually improves after the administration of IV immune globulin. Occasionally, however, a child will present with severe ventricular dysfunction and/or cardiogenic shock. The systemic inflammation gradually subsides and eventually ceases with normalization of inflammatory markers 6 to 8 weeks from the onset of fever. Over time, aneurysmal vessels try to heal through multiplication of cells in the vessels in an attempt to restore a normal lumen diameter. This process is called myo-intimal proliferation. The smaller the initial dilation, the more likely the vessel lumen diameter will regress to a normal size. However, even if the lumen size is restored, the affected vessel may not be completely normal. The walls of these vessels are thicker and may be subject to scarring and calcification, or potentially causing stenosis, especially at the distal ends of the aneurysm in patients with large aneurysms. So almost all of the morbidity and mortality resulting from Kawasaki disease are due to cardiac complications and mainly occur in patients who have giant aneurysms. Coronary thrombosis may result from sluggish blood flow in a dilated or aneurysmal vessel. Over the years, in patients with large aneurysms, stenosis and scarring may lead to impeded blood flow, which can result in myocardial ischemia or infarction. For the assessments, first we have risk assessment. For the physical examination, So the appearance of the patient. Patients with Kawasaki usually appear lethargic. For the vital signs, they have high-grade fever. For the skin, erythema, edema, jaundice may or may not be present, and desquamation may occur on the palms of the hand and the soles of the feet, as well as perianally. Rash may also be limited to groin and lower limbs. Pustules, macules, and pustules may be rarely seen. Buse lines are seen as transverse grooves along finger and toenails. For the HEENT, strawberry tongue, fissuring of lips, erythematous oropharynx without tonsillar swelling, conjunctival injection, high-frequency sensorineural hearing loss may or may not be present. For the neck, cervical lymphadenopathy or lymph nodes are greater than 15 millimeters in diameter. Neck stiffness may indicate aseptic meningitis. For the lungs, pneumonitis may be present and is demonstrated by fine crackles upon auscultation of the lung apices bilaterally. Rhonchi, vesicular breath sounds, and expiratory or inspiratory wheezing. For the heart, arrhythmia may or may not be present, tachycardia with regular or irregular pulse. For the abdomen, diarrhea, vomiting, abdominal pain, hepatomegaly or splenomegaly or hepatosplenomegaly. For the genitourinary, orchitis may be present, and for neuromuscular, facial palsy may be present. For the signs and symptoms, fever for at least 5 days, presence of at least 4 of the 5 following symptoms. First, changes in extremities, acute erythema of palms and soles, edema of hands and feet, subacute pharyngeal peeling of fingers and toes in second and third week. Second, polymorphous exanthem, bilateral bulbar conjunctival injection without exudate, changes in the lips and oral cavity, erythema and cracking of lips, strawberry tongue, diffuse injection of oral and pharyngeal mucosa. Cervical lymphadenopathy, nodes are greater than 1.5 cm in diameter. This is usually unilateral. So currently, there is no specific diagnostic test exist for Kawasaki disease. For our nursing diagnosis of Kawasaki disease, first we have parental anxiety related to a lack of knowledge regarding Kawasaki disease. Kawasaki disease is a frightening illness due to the danger of coronary artery aneurysm formation. Because they may never have heard of the illness before their child's diagnosis, parents need both information about and support throughout the lengthy disease process. Next, we have acute pain related to the inflammatory process of Kawasaki disease. A child with Kawasaki disease is uncomfortable from the joint involvement, edema, pruritic rash, and abdominal discomfort. The high fever can lead to dry, cracked lips. Providing additional comfort measures such as rocking and holding or distraction may help. Lastly, we have risk for ineffective peripheral tissue perfusion related to inflammation of blood vessels. Ineffective tissue perfusion occurs when the exchange of gases, nutrients, and waste within the blood vessels is impaired. For the managements, nursing management, first, monitor pain level and child's response to analgesia. Second, take vital signs as directed by conditions. Assess for signs of myocarditis, tachycardia, gallop rhythm, and chest pain. And monitor for heart failure. Closely monitor intake and output, and monitor hydration status by checking skin turgor, weight, urinary output, specific gravity, and presence of tears. Then allow the child periods of uninterrupted rest. Encourage the child to move about freely under supervision. Provide soft toys and quiet play and encourage use of hands and fingers. And provide quiet, peaceful environment with diversional activities. Then offer cool liquids such as ice chips and ice pops. Progress to soft, bland foods and give mouth care every 1 to 4 hours with special mouth swabs. Use soft toothbrush only after healing has occurred. For the medical managements, first admission to the nearest hospital must be warranted. Intravenous fluids should be instituted in order to prevent further dehydration. The standard treatment involves the prevention of serious cardiac complications with the use of intravenous gamma globulin. Aspirin is used as a complementary dose with IV gamma globulin. Steroids are also ordered in order to prevent inflammation on joints as well as valves of the heart. For the pharmacological managements, first we have intravenous immunoglobulin. IVIG relieves acute inflammation and has been shown to reduce the rate of coronary aneurysms from greater than 25% in untreated patients to 1 to 5% in treated patients. Maximal benefits are seen when IVIG is given within the first 10 days of the illness. Next is aspirin. It has a synergistic effect with IVIG and has long been a standard part of therapy for Kawasaki disease. Patients on prolonged aspirin therapy must be instructed that concomitant use of ibuprofen antagonizes the irreversible effect of platelet inhibition by aspirin and should be avoided during therapy. Additionally, the risks of developing Rey syndrome during an active infection with influenza or varicella should be addressed. Next, other adjunctive agents. In addition to their use in treatment of IVIG-resistant Kawasaki disease, corticosteroids have been proposed as part of primary therapy. The roles of other adjunctive therapies, including pentosyphylline and abscesimab, have not yet been definitively determined. Pentosyphylline acts as an anti-inflammatory agent by inhibiting tumor necrosis factor alpha and may reduce the incidence of aneurysms. Abscesimab is a platelet glycoprotein 2B or 3A receptor inhibitor and has been used in conjunction with standard therapies in patients with Kawasaki disease and giant aneurysms. Lastly, anticoagulant therapy. Anticoagulants such as warfarin and low molecular weight heparin are used in patients with large aneurysms in whom the risk of thrombosis is high. The goal is to maintain an international normalized ratio of 2 to 2.5. For the surgical management, we have coronary artery bypass surgery. So this is the pathophysiology of Kawasaki disease. For the predisposing factors, we have age, sex, ethnicity, environment, and genetics. For the precipitating factors, there is none. So the etiology of Kawasaki disease remains unconfirmed. KD involves widespread inflammation of the small and medium-sized blood vessels, with the coronary arteries being the most susceptible to damage. Kawasaki disease can be divided into an acute phase, which is the week 1, and subacute phase, which are weeks 2 and 3. For the signs and symptoms, fever for at least 5 days, presence of at least 4 of the 5 following symptoms. First, changes in extremities, acute erythema of palms and soles, edema of hands and feet, subacute peeling of fingers and toes in second and third week. Second, polymorphous exanthem, bilateral bulbar conjunctival injection without exudate, changes in the lips and oral cavity, erythema and cracking of lips, strawberry tongue, diffuse injection of oral and pharyngeal mucosa. Cervical lymphadenopathy, nodes are greater than 1.5 cm in diameter. This is usually unilateral. For the managements, nursing management, first monitor pain level and child's response to analgesia. Second, take vital signs as directed by conditions. Assess for signs of myocarditis, tachycardia, gallop rhythm, and chest pain. And monitor for heart failure. Closely monitor intake and output and monitor hydration status by checking skin turgor, weight, urinary output, specific gravity, and presence of tears. Then allow the child periods of uninterrupted rest. Encourage the child to move about freely under supervision. Provide soft toys and quiet play and encourage use of hands and fingers. And provide quiet, peaceful environment with diversional activities. Then offer cool liquids such as ice chips and ice pops. Progress to soft, bland foods and give mouth care every 1 to 4 hours with special mouth swabs. Use soft toothbrush only after healing has occurred. For the medical managements, first admission to the nearest hospital must be warranted. Intravenous fluids should be instituted in order to prevent further dehydration. The standard treatment involves the prevention of serious cardiac complications with the use of intravenous gamma globulin. Aspirin is used as a complementary dose with IV gamma globulin. Steroids are also ordered in order to prevent inflammation on joints as well as valves of the heart. For the surgical management, we have coronary artery bypass surgery. For our nursing care plan, we have acute pain, subjective cues, crying, extreme irritability, refusal to play, and increased rating on pain scale. Next, for our objective cues, we have high-grade fever, tachycardia, dry and cracked lips. For our nursing diagnosis, we have acute pain related to the inflammatory process of Kawasaki disease. Scientific basis. Kawasaki disease causes swelling or inflammation in children in the walls of small to medium-sized blood vessels that carry blood throughout the body. Kawasaki disease commonly leads to inflammation of the coronary arteries, which supply oxygen-rich blood to the heart. The inflammatory response can also affect lymph nodes. For our objectives of care, our general objective is after 5 days of holistic nursing care, the client will be able to demonstrate relief of pain. For our specific objective, after 24 hours of nurse-client interaction, the client will maintain stable vital signs, experience less pain, and express understanding of medications used to treat inflammation. For our nursing interventions, our independent nursing intervention is to maintain the child's room distraction-free and keep it dim. The darkness reduces eye discomfort caused by conjunctivitis. Then apply cool clothes to the skin, lotion, and soft, loose clothing on the child. Alleviate skin itching, therefore promotes comfort. Next is handle child gently and avoid unnecessary movements. Movement causes discomfort. Next is apply lubricating lip ointments and glycerin swabs to the oral mucosa. Offer cool liquids and soft foods. Moistens dry oral mucosa to lessen discomfort and promote oral intake. For our dependent nursing intervention, Administer IV immunoglobulin and high-dose ASA therapy as indicated. This decreases inflammatory process and helps decrease fever. For our interdependent nursing intervention, explain to the parents reason for child's discomfort or irritability. This promotes understanding and cooperation.